Yeah, exactly. كده خلاص.
You can start. Bismillah.
Okay. Bismillah ar-Rahman ar-Rahim. Salaam alaikum. Hello, dear colleagues. I'm sure that you're all enjoying a very or excellent presentations and talks, just like that I do. And now we're going to go and navigate through a highly interesting area of simulation. We will start by Dr. Yunus. Dr. Yunus is highly experienced director and researcher, specialized in simulation-based education, innovation, and driving transformation in this field. With expertise in both education and technology, Dr. Yunus is at the forefront of shaping the future of learning.
يا محمد
So, Dr.
النبي يا محمد
Yunus,
خليك معايا من فضلك.
Dr. Yunus is the ideal consultant for
النبي شو بس
establishing
السيشن
and
دي عشان واحد
utilizing
النور قطع عنده وواحد
ده الاكونت بتاعك انت؟
ده بتاع عاصم بتاع عمك.
طيب
not sure.
تعالى يا حسام هنا تعالى خد
طيب
واحد.
معاك هشام اهو.
So Dr. Yunus is going to be the best candidate or
خلاص
the
اعمل
best
ايه؟
person.
ممكن متابعين؟
Yeah.
دكتور هشام ممكن تكلم باشمهندس احمد؟
Yeah, just to mute. So Dr. Yunus Zaidun, the floor is yours. Please step in.
Thank you very much, Dr. Tahra. I don't know, can you hear me? Is this sound clear?
Yeah.
Yes,
Yeah,
yes,
very good.
very clear. Thank you.
Okay, thank you, Dr. Tahra. Thank you, everyone. So good evening, everyone. I'm very pleased and honored, very humbled by the invitation. So I would like first to thank the organizing committee, so Professor Mardi, Dr. Hisham, and everyone in the committee for inviting me in this beautiful event. I would love to visit the country, but we will wish that the situation in the country will be better, inshallah, and that we can all be soon together around maybe ChedCon 2024. So again, thank you very much. So I will go ahead with the slide about the topic that we will be covering today. So we will be speaking about how we can establish a simulation center, or what we can call clinical skill simulation center. So we will see that the definition for such an institution can be different, but basically the practice and the overall objective of such an institution will be the same. So I'm Dr. Yunus. I am the director of the Simulation Center here in Dubai Medical College for Girls. I would love, again, I would just to make sure that my slides are moving. Any confirmation that slides are moving so we can go ahead?
Yes, we can see the disclosure.
Okay, thank you, Prof. So first, I would love to disclose that I don't have any financial, any conflict of interest or any financial disclosure that I should be disclosing with you regarding the material that I will be covering in this presentation. And I think with the very beautiful introduction that Dr. Tahra did for me, I don't have to go through this slide. So basically, I'm Dr. Yunus Zaidun. I am the Simulation Center Director here in Dubai Medical College for Girls, and I have been taking many roles in different simulation centers before. So I've been working in different countries, basically my home country, Morocco, here in Dubai, and I've been helping other institutions around the world to establish their simulation center or their simulation program. So I have a PhD in mobile learning applied to virtual patients. So this is how everything started. But basically, I've been in the simulation field for more than a decade now. So I've been working with different parties, industry, and institutions like universities around the world. And also, I have I have a lot of interest in research, so I've been doing some research in the past regarding mobile learning, game-based learning, and artificial intelligence, and of course, simulation-based education. So without further delay, I would love to start my presentation by showing you something that is the current state of the art, means that a lot of educators, what they are asking today, and education managers, when it comes to simulation, of course, what they are asking today, a lot of them, they're asking about how they can optimize their resources, how they can, for example, drive their simulation more efficiently. How can they bridge their gap between the knowledge or the theory in their program and the practice that they want to establish? How they want, for example, to reduce their costs, enhance the learning experiences. So all of these questions are the questions that today educators are still asking. We will be looking at the slides today, and we will discover that if you approach this project in a scientific way, in a pragmatic way, you can avoid a lot of these questions, and you can be running your simulation very efficiently. So let's first start by speaking about from where this importance of practice or training practice in a control environment all started from. So we know that the theory part in a medical or any healthcare curriculum, it's very important, but you can all notice that today the practice is very important as well. In a lot of institutions, they are making and they are putting a lot of efforts and a lot of resources into this, so they can establish a control environment for their students, so they can practice until they can gain some dexterity and gain some experience, a basic experience, so they can go for their practice later on. So the landscape is changing very fast now for community of practice that can be done in a control environment. So again, why are we keen on this practical training first? So basically because we want our patient to be very safe. So we want safety for our patient. We want to train our students in an interprofessional way, because they will be doing that later on in their practice. They will be working in teams. So they will be working with nurses, technicians, a lot of people that they can help them in their practice. So we want to train them in the same way, so we can prepare them for that. We want to enhance their skills and develop their skills. We want them to develop some abilities for problem solving abilities. And we want them, of course, to be confident about their knowledge, so they can apply their knowledge. So next slide. So let's try first to identify a definition for what is the term of clinical skill simulation center means. So there is a lot of definitions that you can find out there, but basically the one I could agree on, or more consensus can be on, is that a clinical skill simulation center is a dedicated facility that is designated or designed to replicate the real world healthcare setting for immersive and hands-on training. But basically this is saying that we should be in a controlled environment for our students, to provide them with a safe, controlled environment for their practice, so they can be doing some mistakes, and then we can work on those mistakes to make them better with time, and then release some good doctors and good nurses in the future. So what is the key features when we speak about a clinical skill simulation center? What is the key features that we should see in there? So basically we should see a realistic simulation means that the infrastructure or the environment that we are replicating in our simulation center should be authentic, means that it should be replicating or mimicking the real world setting for healthcare environments like hospitals. For example, if you want to simulate an ICU, so the simulation part or the area for the simulation should be replicating an ICU. We should see some ventilators in there. We should see the whole environment in there, so the student will be immersed in that environment. Second thing, we would like to see some multidisciplinary training. Means that if you train them early to be practicing in a multidisciplinary way, later on they will find that synergy between them in practice being very natural. So we want to have that in our sim centers as well. Standardized patients, well, it have been covered, I think, with the assessment part. So we know that standardized patients are very important concept, very important acts in simulation. So we would like to involve trained actors. So we want to train those simulation or simulated patients. We want to make them grow with our curriculum, means that we want to train them on how, for example, they can take roles in assessments. We want to be able to standardize those patients as well. So that should be also in your simulation program. And of course, the feedback and debriefing, because I would like to emphasize on that. In simulation, would like to say that simulation is just an excuse so we can debrief later on. So whatever will happen in your simulation, we would like to take our students to debriefing, so we can conduct a debriefing with them, and we can construct the learning in there. And of course, the feedback that we will be gaining from those students, so we can make our simulations even better with time. So when I think about simulation and the landscape of simulation, I will always, for example, cite this great work from the higher authority of healthcare in France. Basically, I adapted this from them, but basically this is covering the whole spectrum of simulation that we can see today, either organic or non-organic. So we can see, for example, on the organic part that have been done from decades, is that we have been able to use animals, so we can practice and we can enhance our skills, for example, surgical skills mainly. We have been working on cadavers, and at some point they are considering this also as part of simulation, as we can practice on those. And then we can get to the organic part, starting with the standardized patient, or some like to call them, even if there is a little bit of disparities in that, but basically standardized patient or simulated patients. Then we can use the full body simulators, which is the most common or most famous way of using simulation. Either it's high fidelity, mid fidelity, or low fidelity. Then there is the past task trainers, or we can call them also procedural skill trainers. And then the virtual reality, which is taking a lot of space today in simulation. And then the digital simulation with some softwares that can be applied specifically for those. So this is the full spectrum of simulation. And then we can see later on some sub-categories that can emerge from those. But basically, those are the top categories that we can see all can relate to the healthcare simulation. So when we think about establishing a simulation center, we should have a holistic approach to that. We should have scientific way, or that is more close to project management. It's a project, so we should tackle that in a very systematic way, so we can know which step can be first, and then we can go to the second step, and then third step, and so on. So basically, as a project manager, as also. Everything will start with a need analysis. So either for any need that you will be covering later on, you should start by gathering the need in a systematic way. So there is a lot of frameworks that you can use out there. Some they like, for example, to use the 5Ws. Some they like to use the 5W1H, or some they like this one. The most I would say the most generic one can be this 5W2H. So basically, we have to address the why we are doing this project, why we are establishing a simulation center first. So we have a mission with that. Then we can start with what are we building at? Is it a lab or a center? Is it one specialty, 3, 4, many specialties? So this can be addressed with that. Then we can say, we can ask ourselves another question, which is the who. So for whom we are doing this? Is it for medical students? Is it for nursing students? So what is our target group for that simulation center? Then how are we going to do that? So either we are doing it on ourselves, maybe we are collaborating with other institutions that would. Everything can be, for example, addressed in that. We can ask ourselves the other questions. For example, where are we going to do that? Will it be with our facility, or we will be building a new facility for that? The time that would take, how much will that cost? How can we, for example, finance that? So all of these can help us tackle this exercise and gather a very good need analysis that we will be doing, so we can know exactly what we are doing and how are we doing it and when are we going to do that. So the second step would be to establish a strategic plan for our institution. So we decided that we'll be doing a simulation center or a simulation lab, well, clinical simulation center or clinical simulation lab. So first, we did our need analysis. We know for whom we are doing that and how and when. Now we should establish the strategic plan for our institution. So first, we have to get a mission for our simulation center, maybe the vision for that, the values, and maybe the mission, for example, will be aligned with some strategic plan in the country, for example, like the case here in the UAE. We can align with that. Maybe the Ministry of Health or Ministry of Education, they have an overarching, for example, mission that we can align on that. So we can think about that, and then we can align our center with those. Then we can get a little bit further with our strategic plan, and then we can decide on what is our goals with that simulation center. They can be micro or macro. They can, well, for example, in this slide, I'm putting just 4, for example, but they can be more than that. And the whole exercise with the strategic plan will be enabling you to establish a brand for your simulation for your simulation center, which is very important later on. For example, if we are going towards revenue generation, you want to make money for your institution so it can be sustainable. So for sure, you have to establish a big brand, a very strong brand for your simulation center, so people, they will remind themselves with whatever training you are doing, and then they can be interested later on that. So the third step would be to go to those big societies out there. In simulation, the most global one would be the Society for Simulation in Healthcare, SSH. CSAM is the European one, so Society for Simulation in Europe, and INAXL is basically for nursing, the Nursing Association. So all of these 3, for example, big societies, they have already did the work for you at some point. So they have, for example, repositories that you can access, which it will have, for example, some guidance that you can follow up, and then establish your simulation center based on those. So those, they will be releasing what we call best practices. So those best practices, you can establish them in your simulation center, and later on, following those best practices, you can get to be accredited with those societies. So all the 3 societies you can see there, all of them, they are offering some accreditation that you can have, and this accreditation can elevate the visibility of your clinical simulation center. So the 4th step would be to think about your infrastructure, your technology level. Basically, I know that this goes hand in hand with the budget that you will be having. Basically, if you have more budget, you can have more enhanced infrastructure, I would say. But basically, you should think about this as access for development for your infrastructure when you are establishing your simulation center. So first of all, you should think if your infrastructure is flexible enough. Flexible means that, for example, let's say you don't have enough money to develop your simulation center, but basically you can develop some of it. So think about the flexibility of your infrastructure, so later on you can add on it and continue your development with your simulation center. Then the interoperability, for example, means that you can have some systems, but think in the long run, you might change your mind, or you might go ahead with another software that should be connected with that. You should think that this software should be interoperable with your infrastructure, so it can enable you to work with it later on. The infrastructure should be also authentic to your simulation center, because this will be something that will be making your sim center standing out of the competition, for example. It should be futuristic, because the sim center will not be something that you will invest on it today, and let's say in 2-3 years you will have another budget to invest in your infrastructure. This is something that will happen and will stick with you for 10, 15 years. So you should be thinking about the future as well. It should be data driven, because basically whatever we've been talking about in this conference, basically data is gold today. So when we are doing simulation, we can retrieve a lot of data as well. So we can work on those data, so we can collect them, and maybe we can enable some research in our simulation centers. And of course, because we are working on a very active learning experience with our students, so it should be student-centric. So the fifth step would be to establish our sim center, would be to think about the faculty development. Well, I was doing some nice animation in this slide, but basically it didn't work, so I went for the PDF, but just bear with me. So the latest studies have shown that a big percentage of the mannequins that sim centers have, either it's not utilized or it's very poorly utilized. So all of this can be related to the lack of engagement from faculty. So basically, you should. There is some studies also that call them the skeleton in the closet. Some, for example, because they purchased that very high-edged like mannequin. So, for example, they don't even want to talk about that mannequin because it costs too much, but they are not using it enough. So you should involve your faculty from the starting of the project, from the inception. So, for example, you can brainstorm with your faculty, thinking about what you will be developing next, and then work on some training in advance, and then after that you can get whatever equipment that will be serving that program. So think about some faculty that you can engage with simulation, and that they can take ownership of that simulation and take it further with their trainer. So faculty programs, they should be something that is essential with your program in simulation. You should train your faculty very frequently. You should keep them updated with whatever technology in there. And there is a lot of studies, as I told you, either in nursing programs for simulation or medical programs, that shows that this is very highly related, the usage of sim centers and the faculty development and faculty engagement. Well, the funding part is the most interesting part, because basically if you don't have money, well, it will stay as an idea of yours. So basically you can think about a lot of ideas that you can fund that project and look for a lot of resources out there. So for example, you can have your institutional budget, which is, it can still happen in some institutions. If you have some nice faculty that they can join forces with you, and then you can work on some grants. Maybe you can accumulate grants for that project and scholarships. You can reach out for private donations. We all know that this can be part of Sadaqa Jariyah as well, because it's part of a noble cause, which is education. You can partner with industry, which is something that is very unlikely seen in sim centers, clinical sim centers, but basically this is something that is very doable and achievable. So if you are very interesting and appealing as a program, you can bring those partners to your project, and you can build that sim centers based with industry, for example. I've seen that in a lot of surgical simulation projects. And then, of course, government funding. If you establish simulation as a evidence-based practice, also for medical education or for nursing education, government can be interested also. They can work on some projects for funding such a project for you. Well, we spoke about how we can establish the sim center, but basically if you have already a sim center, or you join the sim center that is basically maybe lacking of usage, for example, in this section we'll be speaking about how you can fully utilize.
Hello, Dr. Yunus. Yeah, very interesting talk. Can you just try to speed up?
I will speed it up.
Yeah, thank you.
Yeah, so the user of sim centers, first you should think about your code of ethics. There is, as I told you, SSH or CSAM, they have some published already, so you can have a very strict and very visible code of ethics for your sim center. This is very important. You should think about how you can engage the simulation in your curriculum and incorporate your simulation in your curriculum, because If you don't do that, basically you cannot be sustainable as a program. You should think also about your flow of operations, because this is something that you have to operate every day. So you should have from scenarios, your standardized patients, the training you are doing, part of the assessment. We've been speaking about the assessment part also that can be enabled by simulation, and of course your debriefing. You should have a structured debriefing that can be standardized in your simulation center. So part of that is that you should have a very strong policy manual. So everything should be on records. Everything should be following a certain way of doing things. For example, you should have a template for your simulation scenarios. Either it's for SPs or either for mannequins. For procedural skills, you should have something like that also, so you can keep records for later on if you want to go for accreditation. This is something very important that those reviewers, they will ask for. Then cultivate the data-driven culture in your simulation, because you will need it either for research or either for continuous improvement of your program. This is very important, and this is very related to the simulation management system that you will be having in your sim centers. So you should be thinking about that as well. And then the inventory part, because this is something that is very important in your long run. You should be thinking about how you can keep a very organized inventory for you to see and drive your simulation operations every day. Well, I know that there is not a lot of time for me, but basically I will just speak about some cases. So for example, this is a simulation center that we started on 2014 in Morocco. The sim center is called IMSC. That was in 300 square meters. And you can see that, for example, with faculty engagement, you can grow that to be something like this. So later on, in 2 years, we build up this simulation center to be the biggest in Africa. So it's 4,200 square meters that is covering a lot of all the specialties, surgical specialties and all the medical specialties. So basically with this, there is also the case of MBRU, which I have worked with. And basically this is a full hospital as well with the operating theaters and with emergency department for that. And then our proud, I would say, junior simulation program that we established a year ago in DMCG, which is around 600 square meters that we are building up bit by bit. But basically that is a program that is very promising, that we will be seeing like in 1 or 2 years, that will be one of the biggest simulation programs in the area. So the takeaways from this is that you should be thinking about the simulation enhanced learning as an experience. So simulation for you, it's an experience of learning. So think about that. You should be having strategic planning, because it's very crucial for developing such a simulation and to use your simulation center very efficiently. You should think about your investment very wisely, because you don't have that money coming a lot. So you'll be doing your investment once. So think wisely about that. Of course, I didn't emphasize that enough, but faculty is key. Faculty development and faculty competency is key for the success of your program. And of course, you should be thinking about continuous improvement. So think about the feedback that you will be getting from faculty, from students, from every stakeholders of your simulation center. And of course, this will be enabling your continuous improvement for the program. So I think this is last slide for me. Well, the conclusion basically is that what I said, and thank you for your listening. Thank you very much.
Thank you very much. This is an excellent presentation, very nice ideas and examples. When you talked about the skeleton on the closet, you actually hit a nerve, because I know of some institutions that we have back there that had this problem. So very nice also, and very good articulated recommendations. Thank you very much. Now, our next presenter is Prof. Karim Qayoumi. We are really very fortunate to have him with us, and he's highly accomplished professor of surgery at the University of British Columbia and the founder of the Center of Excellence for Simulation, Education and Innovation. He's also the chair of Technology-Enabled Learning for Vancouver Coast Health. and Regional Director of the Royal College of Physicians and Surgeons of Canada. With his extensive international teaching experiences, he was awarded over 100 or 11 awards, and also he has 100 peer-reviewed publications. His publications, part of them were translated in many languages. I hope Arabic is one of them. And he is well equipped to guide us through the field of simulation and virtual patients. And additionally, his efforts in promoting equity in medical education between developing and developed countries are remarkable. He is a founding director of an organization. It's a profit-free or non-for-profit charity. So without further ado, I welcome Prof. Karim to the stage. Please.
Thank you very much for your introduction. Good. I don't know if it's morning there or evening. It's morning here for me, but maybe good afternoon for all of you. And specifically for my dear colleagues from Sudan. I have been in Sudan many times, and I have a lot of love and passion for Sudan and Sudanese as a whole. And therefore, I would like to cordially thank the organizing committee for giving me the opportunity to speak with you today. I wish I would be there to see you all in person, but maybe Allah subhanahu wa ta'ala gave us a time in the future to be together. But I had some problems with uploading the slides, so we turned it into a PDF, so I hope it's going to work. So today I was asked to talk about the simulation and virtual patient conflict environments. So I believe by the end of this presentation, you will be familiar with conflict zones in the world, negative impact and challenges created by conflict, opportunities that may arise for virtual education from those conflicts. And also, I would like to unveil our out-of-the-box solution on what to do in conflict zones using a virtual simulation. So I believe you all very aware know about all the conflict zones in the world, including Syria, Afghanistan, Iraq, Ukraine, Ethiopia, Burma, Libya, South Sudan, or maybe Sudan itself, and Karabakh, which is between the Azerbaijan and Armenia. And lately, we all heard about Palestine. So the problem is that these conflicts are not going to disappear. It's going to get worse and worse. And some of these conflict zones are not permanent, but for a long time. So it's we don't need a patching a procedure to support medical education. We need something fundamental to support ongoing conflicts, not just in one region, but with all the regions around the world. So talking about the negative impact and challenges of education in a conflict zone, the biggest problem is disruption of education systems as a whole, and medical education is not an exception. This leads to loss of learning opportunities for students. Why it happens? There are lots of reasons, but the main reason is that erosion and destruction of educational infrastructure. Sometimes because of the war, students cannot go to the infrastructure because they cannot cross the roads and it's dangerous. In most of the time, as you perhaps know better as a Sudanese, that most of the human capital are leaving the conflict zones, and loss of educational personnel is the biggest. Human capital loss is the best, the worst thing that can happen in a conflict country or conflict zones. And it's not just displacement of students and teachers, but also the worst than that is the recruitment of students and faculty into the armed forces by force or by choice. Then in all this situation and condition would create a huge psychological impact on students. I would say negative psychological impact on students. And also because in the conflict zone, the cycle of poverty is increased, people would think more about survival and food than education. And it's very petty. And that brings the humanity backward. So within this conflict and problems and destructions and negative impacts that we are talking, there is some opportunities also for virtual education. As we said, the most important part is access to education, because students cannot have access to education, whether the infrastructure is destroyed or they cannot get to infrastructure. But with virtual education, we can actually improve access for education, so we can have the continuity of education for students on their home at their conditions, whatever they have. And in addition, I think the virtual environment in digital education would give more flexibility and adaptability, provide the environment to develop skills and capacities. It's the best source of resource optimization. Can you imagine if people cannot go and see a book in a library, you can bring all the books to the person, to the students in their home environment. And the most beautiful thing about this is that through virtual education, students in the conflict zone becomes an integral part of the world. They're connected to the network of their peers, and they don't feel alone. And that would reduce significantly the psychological impact for the students. At least virtually, they are in touch with their peers all over the world. And if they're connected around the world with conflict areas, then they would know what the situation and condition is there. They don't feel like it's only to them. So there are other people in the world that suffers like them. But for me also, as a technology development person, conflicts are an important part that provides the environment for innovation and technology adaptation. I preached, virtual simulation from year 2000 to 2019, and nobody listened to me. Nobody was thinking like, no, I have to see a patient. I cannot do this. But COVID came with all the negative impacts. During COVID, everybody was calling me, Dr. Kayumi, can we have cyber patient? Can we use virtual environment? So the negative impact of negative things in the world, such as wars, such as diseases, will create an opportunity for us to find out-of-the-box solutions and develop more technology, more adopters into the technology. So what is our solution? So our solution, out-of-the-box solution, is to build a virtual medical university that would support conflict zone all over the world, and to design a unique curriculum based on state-of-the-art technology and modern pedagogical theories. And I have to tell you that we have already completed that and it's called Canadian Virtual Medical University. We're in the process of registering it, and starting the second part of January, we're enrolling students into. The first group of students would be enrolled are girls from Afghanistan who were deprived from education, as we all know, and we provide the education for them. But we also have students from other parts of the world, such as Ethiopia, Uzbekistan, and I would love to have maybe some students. I would even reserve 25 seats for Sudanese students to come and join this virtual university. So I'm gonna, in the next few slides, tell you a little bit, a high level of what this virtual university is about and how it is done. So in order to build this university, we had to have a out of the box a curriculum design and concepts. So our concept is very simple. It's not out of the box, but it's simple. It's a student-centered, competency-based curriculum. So what it does, the important properties of the student-centered, competency-based curriculum is that it's not bound to time and space. It's the entire curriculum is asynchronous. So it's based on competencies, not just knowledge, and it's responsive to. Oh, I'm sorry, it just went. So it is it's responsive to students' needs. Something is happening. It's just going back and forth without me doing anything. I'm so sorry about that. And also it emphasizes on critical thinking, problem-based learning, and other things. So yeah, this doesn't work. I don't know why. Is somebody doing this? Can you not please advise my slides? Anybody's doing that? No? Okay. Thank you. Please don't. Yeah. Oh yeah. It's just doing it by itself. So
probably you're touching on the mouse.
No, I'm not touching it. No, I'm not touching it. My hands here. See, it's changing. So it's very cute, but I don't know why it happens. It's I don't know how to do that. Maybe I can increase it, and so okay. So we're gonna talk about the so let me go back to the other slide, because I have to talk to you about the important aspects of its strategy. So we're talking about the properties. So we talked about the properties of this kind of a curriculum, but we also can talk about the strategies. So it's active learning, it's collaborative, it's reflective. In that reflective practice includes case-based learning, problem-based learning, team-based learning, and simulation. So the curriculum components, like any other curriculum, includes needs assessment, learning objectives, content and syllabus, strategies for delivery, and methods of assessment and evaluation and feedback. So all of that is all electronic and asynchronous delivery. So we can talk about this maybe a little bit more later. So the curriculum is divided into 4 levels, because there is no years and semesters. So level 1 consisted of the foundation of, oh my God, this is not happening. So it's all include foundation of medicine, which is no, this is not gonna work. I don't know what to do with this. So
would you try to stop sharing and share back again? Probably it will work.
Sure, because it's really disrupting the yeah. Why it is? I try to do my slides, but it doesn't do share slides. So we turn it into PDF, but the PDF has the minds of its own, kind of. In the beginning, it was okay, right?
Indeed.
Yes. Okay. So so we talked about this, and the level 1, but the level 1, in addition to the foundation of medicine, it will have I have to do this. No, it's impossible to do this. So I don't know what.
Would you like to share these slides so that we can
Maybe.
share it from our end?
Maybe we can. Maybe I will try to do my slide. Maybe this time the slides would be okay. Just 1 second.
Probably. Yeah.
I'll try to do it. If not, and in the meanwhile, I'm gonna send this to the PDF to maybe. Just wait a second. I think maybe I can. This is okay. Share screen. It doesn't share the screen. See that? So
Can you tell us what you see when you click on share? What do you see when you click on share?
On share, this is what you see. Do you see that? It says a screen says select a tab to share.
Yeah,
So
tab means
window, maybe window, Chrome tab.
you will select window, but after you start your presentation and make it in presentation mode.
Okay. So maybe
you start that PowerPoint.
Okay, so now I'm gonna share the screen here. Oh, okay. So maybe I can do. Do you see?
Yeah, we see. You need to start the PowerPoint presentation, not from the platform. You go to your computer and start the presentation.
Yeah. I started it, but you don't see it, right?
Okay. Then you click on share and select window.
Oh. Select window. Yeah. Oh, okay.
In the window there is presentation.
No.
What do you see in the window?
And the window, I see the keynote. It says the Chrome, and that's it. And there's a keynote. So maybe I can share the keynote and we'll share it now. No, it's not sharing.
So perhaps you can just post it to me, the email. It will take only 1 minute to upload it in the screen.
Where to give you the slides or the PDF?
Either of them.
Okay. So I can share you the PDF. Maybe it's easier. Okay. Do you have it?
You send it to Shetcon, right?
Yeah, I send it to share. Yeah, just 1 second. It opened it somehow. Okay. Now I send it to you.
In the email? Oh, yeah.
No, on the chat.
On the chat, all right.
Yeah, on the chat. You must receive it. Well, I can talk to you without the slides. That's okay.
So to share it in the chat, it's better to click on resources, the icon just below the polls in the screen.
Yeah. What would you like to share? And I just put it in there, and there's this.
Yeah, because I can't see it yet. So there is, under the poll, there is an icon called resources. When you click on resources, you can upload the PDF file there. At the right side of your screen.
Yeah. Oh, it opens. Do you receive it now?
Not yet.
No, it just opens it here. But maybe if I share it, maybe if I can share it here, it will come handy. Oh.
So I will write in the chat my personal email so that you can share it directly, if that's helps.
Okay. I think for the interest of time, I'm just going to go through the rest of it without the slides, but I can explain the things to you. You're all educators; you would understand how it is. But it's very pity that I cannot do this, because I cannot. I have to go to my my slides to like to your email, right? Did you send me an email right now, or? And I have thousands of emails here at this point. Is that okay with you if I just
I think you can. Yeah,
just for the interest of time, you have to just gonna open my slides here and just
it will be very easy for you to explain it even without using this aid. So
yeah. Without slides, I can do no problem. I can. So that we were talking about the curriculum components, and then the curriculum levels. So the curriculum we have 4 levels of the curriculum because we don't have semesters. So level 1 is the foundation of medicine, which include anatomy, physiology, biochemistry, and all that. In addition, we have a patient-centered care, doctor-patient and society relationship, medical ethics, and a few lectures about scientific method. And then in the level 2, we have organ system-based pathology. So the students would go through all the system from respiratory, cardiovascular to digestive and other systems. And also in the meantime, they will have the lectures on theories behind CANMET competencies, clinical reasoning, and basic skills. And level 3, they would have they will learn clinical skills specific to 5 main clinical specialties, which include internal medicine, surgery, OBGYN, pediatrics, and psychiatry. So this is kind of equivalent to clerkship level at the normal medical schools, but the difference is that this would all be virtual, and they can do it from their homes using different technologies that I will introduce for you afterward. And also during this level 3, they're going to learn clinical reasoning, and they're going to learn how to apply CANMET competencies into the clinical environment. So level 4 is actually a transition from virtual learning into real life medical practice. So in this level, students would apply whatever they learn in virtual reality into internal medicine, surgery, OBGYN, pediatrics, and psychiatry. And they will develop more hands-on working with real life patients and real life clinical environment. And in addition to that, in this level 4, we will teach them a lot about career planning, procedural competencies, and we prepare them for UCMLE, LMCC, and EPA examinations. So I have here a diagram. Unfortunately, I cannot show it to you of the whole medical curriculum. And also I have a flow chart of medical curriculum on how the students would go through the system. I have also some charts on our competency-based model. So if I can explain it to you verbally, so the curriculum is based on EPA's entrustable professional activities, and then each entrustable professional activity is divided into functional competencies, and then each functional competency is divided into several milestones, and then each milestones are connected to a cognitive, psychomotor, or affective domains. And also, in addition to functional competencies, the EPAs would also include core competencies, which would include mostly doctor-patient society relationships, epidemiology, and things like that. And then the examinations will be taken from milestones. So when they reach the specific milestones, they will pass those milestones and go to functional competencies and go to the whole EPA. So the time is not limited for them. They don't have to, maybe one student would be very talented and hardworking and reach those milestones faster than another student. So we don't have a time limit for them by when they should do that. But we don't have a minimum time, but we do have a maximum time. So they cannot just go forever and be medical students forever. So each level they have to complete within a year. If not, then I have to repeat that year. So to give you just an example of how this competency-based curriculum is designed. For example, if in surgery we have competency, if we have the EPA 1, which is surgical instruments, how to operate surgical instruments, and then EPA 2 is procedural competencies. Like let's say in EPA 2, the procedural competencies, or the functional competencies within this EPA 2 includes wound management, venous and arterial access, basic laparoscopic surgery, and things like that. And then the milestone, for example, for venous arterial access would be venous puncture, arterial puncture, subclavian catheterization, internal jugular vein catheterization, external jugular vein catheterization, Swan-Ganz catheterization, arterial, and all that. And then we know that these milestones are mainly psychomotor, but there are some cognitive and affective in addition to psychomotor to this. And the cognitive aspect is to read a book or something to learn the theory about it. And the affective part of it is that they have to know if they puncture a patient or cut a patient, how to deal with the patient, how to deal with the family of the patient, how to deal with the environment. So the core competencies that would include for this venous puncture, then or EPA 2 procedural competencies would include medical expert, collaborator, communicator, and scholar. So this is how the whole curriculum is designed. And now we used 4 major electronic platforms to support the Canadian Virtual Medical School University. The first one is Lecteria. Perhaps many of you are familiar with Lecteria. They, in my assessment, they are the best electronic library for medical education. And they have enormous number of lectures and things. So for theory, I choose them to be part of this virtual medical school. In Cyber Patient, that is my baby, and I'm producing it, are for clinical competencies, or used for clinical competencies in APAs, for communication, for teamwork. And I have to let you know that for this virtual medical school that's designed for conflict zones, Lecteria and Cyber Patient would be delivered for free. So nobody is making money on them. The Canadian Virtual Medical School is homed in my non-for-profit organization that they were talking about. It is called CanHealth International. So we don't charge students for these educational services. And then we have the LMS. Mostly we use Moodle. A-Tutor also we use in the past, but we use Moodle. And then we have also a virtual presence, because for each of these for each 10 students, we have one local professor and one international professor from Canada or United States, or Europe. So these two professors are meeting the group of students every Friday for 4 hours to do the formative feedback and do. So we use digital health or Zoom even for that purpose. So the assessment strategy in Blueprint is very big, so I don't want to bore you with all that, but it would include formative assessment and feedback from the instructors to the students that would happen twice every week, and then in the end of the week it will be in virtual presence. And then we have the summative assessment and self-assessment as a reflection and peer assessment. So the criteria for formative assessment include virtual seminars, discussions, also daily encounter notes, cyber patient assessment notes, mini access cyber patient assessment by machine, and things like that. We have now AI incorporated with cyber patients, so all the assessments are done by AI. Now, and then we, in the end of the semester, we do the summative assessment, not semester, but level, all summative assessments that would include all the milestones of all the courses that was in that level, and all functional competencies related to that level, and all EPAs related to that level. So we do the criteria for the summative assessment would be that several factors. First is that the average of formative assessment 20%, and then we have the student behavior for online education. So did the student handed assignments on time? Are they curious? Did they do an extra work? 10% is for that. And then the MCQ for cognitive domain, and we have a final examination for psychomotor and affective domains. So we also the final score, the exit exam, for the exit exam to sit on the exit exam is to have 85% or more. The students will go there, and then they're going to sit in the final exams, and the final exam is equivalent to MCQ or UCMLE examination. So the students will be prepared to do their internship, to do their residency training program in any countries, including Canada and United States. So we do also have the evaluation process that would include teacher evaluation, student evaluation, course evaluation, program evaluation, peer evaluation, and reflection. And this is all would be analyzed and gave a feedback to the curriculum to every year to improve the curriculum and support a better delivery. So in summary, first of all, I apologize for the technological glitches that happened there. I hope I could give you some higher level information about the virtual medical university and that we're proposing for conflict zones. And today we have a sufficient technological advances to learn most medical knowledge and competencies virtually. It is particularly important for the conflict zones because we have no other choice. It is an affordable option for medical education in remote areas also without conflict. So it supports also the Millennium Goal of WHO for health education on global level. You're perhaps all aware that by WHO statement by the year 2030, we're going to be deficient 18 million healthcare workers, and no university in the world can support that unless we are going to think out of the box. So thank you very much for your attention and for giving me an opportunity to speak with you. As I said, this environment is entirely open for Sudanese, for Sudan medical education. If any professor has interest to participate, And also, if you have students in Sudan, not out of Sudan, that would like to be part of this, I'll be more than happy to include them in this pilot study. Thank you.
Thank you very much. This is excellent. This offer is really very generous and in time. And I'm really amazed by the way you managed to manage your way through and take us, regardless or despite of the lack of technology, which is education is more than that, of course. This was really very interesting. I almost teared when you talked about the awaited university for girls in Afghanistan, the potential that it has, the impact that it will have in their future, in our future as humans. You are really practicing what you preached. So thank you very much, Dr. Karim. Now we are going to go into our third and last session for this session. So now we're going to have Dr. Lu'ay Suleimani. Dr. Lu'ay is experienced attending physician with a strong background in healthcare education. He specialized in disaster and emergency medicine, health professions education, clinical simulation, and public speaking. So we are waiting for you. He's going to take us through the interesting topic of next-gen simulation in emergency and disaster medicine education. Welcome, Dr. Lu'ay. تفضل.
Welcome everyone. How are you? I hope you had a nice conference. I'm Dr. Lu'ay Suleimani, as they introduced. Thanks for the introduction, and thanks for the whole organizing committee, and also to my dear colleague, Dr. Hisham Dinar, for his invitation. And hopefully it will be a nice. This is at the end of the conference, as far as I know. So I hope it will be a nice, quick, entertaining, and beneficial presentation. So can you see the screen, the slides?
Not yet. Do you want us to?
Okay, yeah. Now it's shared.
You can see it now, huh?
Yeah, we can.
Okay. So the title of my presentation is Next Generation Simulation in Emergency and Disaster Medicine. The purpose of this presentation is educational only. There is no conflict of interest with any of the mentioned entities in this presentation, just only for showing examples of simulation modalities. So the objectives, including the past simulation, if you want to know your future, you need to have an idea about the past and the present. So here it says that in this quote, if you don't know where you come from, it's difficult to determine where you are. It's even more difficult to plan where you are going. So if you want to go back in history, we'll go centuries back if we want to talk about simulation in general. But if you want to talk about simulation in the healthcare specifically, here is an old example in Nepal, Susruta Samihata. This is a documentation of previous using of natural materials like the wood. This wood, they use it for probing, training the health or trainees in health field to do a partial task, which is probing. Resuscitation, this is a famous resuscitation modality. This is based on, inspired by the story of a girl who was who drowned in the Seine River, and then this Leridal he created this model, and then it was developed after an advice from another person. So he developed the chest part. So as most of you may know, that the simulation in healthcare was adapted from the aviation industry. Then it developed into gradually, like here in this example, they developed the high fidelity, starting to have some fidelity of the mannequins. Then here we have cardiovascular exam. Then this guy, David Gaba, is the pioneer and leading simulation guru in the field. He adapted the new modalities in Stanford of simulation to be applied to crisis resource management. So if we want to talk about the types and the next generation of simulation, we will talk first about the different types, and each type of those is developing. Maybe some types are developing faster than other modalities of simulation. We have the high fidelity mannequins or mannequins in general. We have a partial task trainers, virtual reality, and standardized patient. And if we mix any two of those or more, we get the hybrid simulation. As you can expect, maybe virtual reality is growing faster than the other types of modalities, but also the partial task trainers are developing, and we have seeing many improvements and new inventions in this area, and also for the mannequins. Maybe the growth of standardized patient is limited to some practical applications, not to the modality itself. Some people, they add gaming to simulation. Also, high fidelity or here augmented reality is applied also in the field of emergency medicine. I'll try to open this video.
Just saw this man collapse. Now to save this man, you're going to need to use an automated external defibrillator, or AED, which will help restart his heart. Without it, his chances of survival are low. Imagine this is you. You see a man lying on the ground, but now you get out your AR-powered AED. You take out the glasses. AR is now helping you save this man's life. It's automatically alerted the emergency medical services, and it's giving you step-by-step guidance, telling you to take off his shirt so you can place the pads. Now you need to activate the device, and to do so, you need to pull a lever, and it guides you through that process. Now you have two patches that you have to place for sensing and defibrillation. The first is in the left inferior chest, and computer vision guides you so you can place this in the optimal position. Now you guys have to place the right superior patch, and you use the same process. Now the system tells you that it's going to be sensing whether or not there's a rhythm that's shockable. Unfortunately, there isn't. That means you need to start CPR. Hand position is critical, and the system gives you the optimal location. Now, your right compression rate and your right compression depth are also important, and the system has a continuous feedback loop guiding you through the process. By the way, emergency medical services are 421 meters away. Now, stop CPR. It needs to sense whether or not there's a shockable rhythm. Great news. There's shockable rhythm, so stand clear. It's going to defibrillate. And the paramedic now arrives at the scene. And the good news is the paramedic himself also has AR, and he's able to get live event and live vital signs information. You can even get GPS. Just saw this.
Now we are in the era of metaverse, and it's growing. The applications of metaverse and simulation training using metaverse, all these things is now rapidly growing. Another type of simulation, if you search the literature, you'll see that they use this term of simulation when they talk about technical and computer-based programming. So this is not our main area of focus here. We are doing, me and some of the colleagues, a systematic review, and I was looking at simulation in literature with other topics, and I still find a lot of topics talking about simulation in using simulation computer programming. Now we are moving. General tendency, we are moving from the lower fidelity to the higher fidelity. The fidelity is increasing with time and with the development of the mannequins, if we want to talk about the high fidelity mannequins. And we expect things to grow more and more, especially things related to technology and digitalization. In the training area, now this modality of augmented reality is used for training. This is artificial patient. In real life, you don't see that person, but if you wear the HoloLens or the special device for augmented reality, you'll see that interactive session. We used to do tabletop exercising in our disaster drills. Maybe Dr. Hisham, Dr. Dinar, he knows about this. Now they are developing games to go replace the tabletop exercise, so you can do your tabletop exercise using some programs. Virtual reality now on your cell phone. Now we use this program. It's called Second Life for our medical students. It's mandatory. They have to submit the score, part of their curriculum, submit their score in this program. We have subscription in our department. Computer-based system, a good example for it is, for example, in American Heart Association course like Advanced Cardiac Life Support, they have the course they call it Heart Code. So you do all the interactive session practicing with managing patients according to the guidelines, their guidelines, using computer-based system. Now the complexity of mannequins and the scenarios and the targets of learning or objectives are growing also. And this is an example of improving technology of high fidelity mannequins. You can see the sophistication in technology and the features that were not available before in the previous mannequins. Now also we can improve the reality by improving the simulated environment. Those are examples of simulated environment. This is a simulated environment of an ambulance. You have springs there. It will simulate the movement of the ambulance. And we did our course also, one of the courses that we are proud of, which is IMS, In-Flight Medical Imaging Simulation course, where we did this course with the Saudi Arabian Airlines, and Saudi Society of Emergency Medicine. Here is another example from one of the conferences in Riyadh about military environment. This is our course, which has huge demand. It was well perceived by the whole community of healthcare providers in our region. We created this program from the scratch in a mock-up simulator, exactly simulating the airplane where the crew members, they get their training. Here is a demo or a short video of our work.
Ladies and gentlemen, we have a patient who needs medical assistance. We request any doctor or nurse to contact one of the flight attendants.
So simulation also is getting more and more involved in things other than education and training, in improving, for example, the system, the flow, the process development, flow charts, testing the process in the emergency department or in the hospital in general. This was a training we used to do in US during our training in US about the response team and the response to RRTs and code blues. So you can, I also have another project in the emergency department was about pain management and inserting cannula with interns. So you can have many options of using simulation in different areas that never been tackled before using simulation. Also, not only for medical staff, this was a course for emergency communication skills, and it was involving non-clinical emergency staff. Also, we can use it for competition and showing performance, inspiring teams between hospitals. There is a huge area and room for innovation. This was a device we created, me and two of my colleagues, during our fellowship in one of the Harvard affiliated hospitals in US. Now we are we are using the simulation also for testing our drills response for infectious diseases, especially. Here are examples for the development of partial task trainers for specific important high stakes procedures. Here we have the transvenous spacing partial task trainer and also Sangistikia Blackmore tube. Those are not very common procedures, but they are critical procedures. Also, as you may know that we have a specialization in disaster medicine. We do drills so frequently, especially large scale disaster drills, and we are developing the objectives, goals, and sophistication of the drills every time. Now technology is getting involved in practicing simulation and testing also new inventions like this eyeglasses for disaster triage. These glasses will have visual aids to help in triaging patients during disasters. Functional exercises also are getting more sophisticated with the development of the modalities of simulation, so you can have a specific function to test by simulation. Also, there is a growth of people they want to get involved using simulation. They get involved in the drills and exercises, simulation-based exercises. We have psychological support, people from civil defense, different entities, volunteering institutions. So this area is growing also. The parties involved in simulation training. Disaster drills and requirements from accreditations is also an important part, an important area of development and improvement of simulation. Standardized patient is a commonly used now. More uses of standardized patients and sophistication and application of best practices in using standardized patients. It is Dr. Hisham Dinar doing moulage for a specific example during Hajj. Now, every year we are doing new things, testing new objectives, getting higher levels of objectives. Also, the simulation will help you in decision making. We have the eyeglasses, iPads comparison here. This is an example also of using drills and simulation to help in decision making. This was a drill we did, simulation drill, recently in one of the conferences, our society last conference of emergency medicine. And the amazing thing is what was the involvement of new generation of healthcare providers, doctors, paramedics from both genders. And this was one of our inspiring moments when we saw new generations are getting the experience from the previous generation using simulation. Thank you so much. This is the end of my presentation.
Much, Dr. Sulaimani. I would like to apologize on behalf of Dr. Tahir. She had to leave very quickly for something urgent. First, I would like to express my sincere gratitude for all three speakers. They covered the area of simulation fantastically from the different dimensions. Maybe I don't want to keep people long, and I would like to start with a burning question, if people allow me. First of all, a comment. Your three speeches complemented previously given talks. One of them was just before this session, was Dr. Sharon Raymond. He spoke about the Crisis Recovery Foundation Medical School in UK, and how they very similar to the solution provided or offered by Professor Qayyumi. So as you can see, yeah, and these talks complemented each other, and now we have learned a lot about how to deal with our current situation in Sudan. So thank you very, very much. One burning question. Dr. Yunus Zaidoun and Professor Qayyumi spoke about initiatives and how to establish things. And in my talk, I gave a talk about post-COVID-19 technology acceptance and adoption. And in that talk, I spoke about how do we manage change. And Dr. Yunus spoke about situational analysis when you need to start a new simulation center. So my question to both of you, Dr. Yunus and Professor Qayyumi, is about early engagement, because you said it, Yunus, if you don't engage faculty, you have a problem. And if you don't engage them early, you will still have a problem. So it's not, I mean, late engagement is an issue. Engagement is an issue, but late engagement is another issue. So how do you think we deal with faculty? And you had experiences, Professor Yunus, Dr. Yunus and Professor Qayyumi, in establishing these environments, establishing the centers. You did at least 3 big centers, one in Morocco, the MBRU Center, and the one in DMCG. Engaging faculty, how do you convince faculty? I spoke in the technology adoption about the perception of benefit and the perception of ease of use, benefit and ease of use. So how do you engage faculty early so that it's not only the training on how to do it, it is convincing them to actually this is something that is beneficial and doable not only for them but also beneficial to the students and all of that. So you spoke about strategies and you spoke about using it as a project. And in project management, there is a part about the stakeholders and management of the stakeholders and change management in particular. So how do you see we maximize engagement of faculty in these initiatives, like establishing a simulation center or this new virtual university, Professor Qayyum? Effective engagement of faculty.
My apologies, Professor Sahel. It seems that Professor Qayyumi left the scene due to a technical problem. Probably will pass the question to Dr. Yunus.
Dr. Yunus, yes, please.
Okay. Thank you, Dr. Hisham and Prof. Mardi. This is the key, I think. I'm very happy that this was the first question because I think this is the key of the whole presentation. I would have loved if it was with the animation and stuff. I think I took some nice time doing that slide with some animation, but it didn't work. But this will show like how much this is important. As you said it, Prof, I couldn't emphasize enough how much the faculty development and the faculty engagement in such project is very important. Because basically, as a stakeholders, those people you are serving the most for 2 reasons. First, you are replying or you are providing for a need that is in the program. Basically, I will just give some examples. Any teaching that you are doing in any module, for example, and then you want to do some clinical about that, then you need that sim center. So this is first. And then second thing, you should have and align that sim center with the vision and the orientation of that faculty so they can take ownership of that place. That's why we said, and I believe this marked also Dr. Tahra when I said in this slide, and it's in one of the studies, they call that simulator the skeleton in the closet, because basically if it's not used, it's a waste of money. Second thing, why we should investigate why it was not used, not even because it's only related to the faculty engagement or the early engagement from the start, but basically because they didn't take any ownership in that project. For example, I see that the need is big and huge in one of the specialties or one of the areas of the curriculum, and I'm going and I'm buying the very high-end surgical whatever or the very high-end simulator that does such and such, but it's not serving the big need that my faculty have. So I can count on those faculty not being there anywhere in that program. And then this is not good, because basically what you want to do, and I think this is the best practice, is that you engage them in a very early way with brainstorming, for example, say, meetings where you are talking about the whole idea. Okay, I'm not talking about the money, I'm not talking about anything. I just want to borrow your brains for 1 hour and just want to think. Let's say we have a biggest sim center in this region. What you would do as sim educator, as a faculty, what do you want to do? And then I will make them think about projects, make them dream about such and such training that they can conduct, because those faculty, they want to grow also with your program. So it's an opportunity for them to grow as educators and as professors within their like respective fields, and you are just an enabler in that area. And this is what you have to do: give them ownership of your place by engaging them in the project as a stakeholders. And as your prof said, when they are stakeholders in project management, you should engage them in all the aspects, and you should engage them all the time in the project until you deliver that project. And basically, as a manager, you just give them that place so they can come and deliver their training. If they've been involved, for sure they will not even need your okay for that. The place will be busy anyway, because they love to come to you and they love to come to that place. So thank you, Prof, for that question.
Thank you very much. I would like to share with you two experiences that I had. One of them is long time ago, around 15 years ago. In one of the medical education conferences, surprisingly, I presented a talk. It was about how to prepare, manage, and use a clinical skills simulation center. At that time, we called it a clinical skills laboratory. So when I evaluated what was there, I didn't talk about how to do it. I went to the 5 at that time, the 5 colleges that had some clinical skills laboratories, and I asked them the 3 questions. How did you prepare it? How did you identify the needs? And I asked them questions. And then how are you managing? Who is managing it? What are the staff? Where are you storing it? And how do you use it? So the talk was about that. So the first part was the surprising one, because how to prepare, all 5 of them, they gave the task to someone who knows, and he tick, selected the things that they know and think they are the most important simulators and whatever, and they actually established the skills laboratory, but it wasn't used. That was the problem. So that was 15 years ago. So 5 years ago, the Sudan Medical Specialization Board wanted to establish a center. It's in progress. By the way, Professor Ghayoumi was one of the persons who were consulted. And also Abdelaziz, I don't remember his name, Abdelaziz, one senior simulation consultant in Saudi Arabia, but also visited Sudan, and they gave wonderful consultations. And they asked me what I think. I told them about this story, this talk 15 years ago. I told them, you will have a challenge. If you ask them what do you need, they don't know what they don't know what's out there. But you have to ask them.
Of course.
And you have to tell them what is out there, because they don't know. You will tell them that there is this, there is this, there is that. What do you think, and so on. In fact, when I told them that, they didn't do it to start with. And so when they showed me the responses from the different specialties, it was very clear that they don't know what is out there, because they were just asking for things, generally speaking. And I'm sorry I took too much, but that's very.
If I may, I will just in 2 minutes. In 2 minutes, I can give you a similar story that happened to me in my old sim center, and then just about to leave. I had a project to deliver there, and that project was a $5 million project. It was a big, huge project. And again, it was about the same thing. We had our sim center. We grow our sim center to be one of the biggest, but because we grew that sim center at that point, It was a different team managing the sim center. So before I joined, we grew that sim center to be very big in a very short time. So by the time we had the big sim center, we still had a lot, so we can equip. We didn't have that money to equip the whole sim center. So then after that, we worked with some partners, and then we secured some budget. I mean, some budget, it's 5 million, it's a huge budget. But again, we've been back to square one, which is, you have money, what do you want to do with that money? How do you want to do with that project? So it was two things. Either we go with the same way as you said, the classic way, and then we do things for those people, or go with the right way, which is engage them from the start, saying, okay, we have a big budget, we have a big envelope, we will split it on whoever will show that they can earn that with the training they will develop and the curriculum they will develop. And then we went to gather all the head of specialties, clinical specialties, and then we made them make all of them long training and short training. And based on that, we said, okay, we will gather as a committee, and then we will decide how much you will get for each specialty. By the time we did that, we noticed that we have a big deliverable that we can give to our partner based on that work that we did with those head of specialties. And when we got to deliver the project, it was all set in a very beautiful way. Today, I'm very happy to see 6 years after delivering that project that all of these specialties, they are conducting their training, surgical training, with that equipment that they bought, because they felt I was the project manager and they were my clients, my stakeholders, and I was consulting them all the time. What do you need? What do you want? And then I was I don't know, I made that wish happen, and I got them that equipment. By the time I got them that equipment, it's not even, you don't have to do anything after that. They are faculty, they know what to do with it, and they will conduct training.
Thank you very much. Hasham, if there are any other people who want to ask questions, or you can close the session.
Yeah, thank you very much, Dr. Zaidoun. Thank you very much, Dr. Lai Suleimani, Professor Qayoumi. And unfortunately, he's not with us now. And thank you very much, Professor Sahel. Probably this is not the last session, but probably I'll end with a quote we usually use, and probably Dr. Lai remember this. We have a say in the emergency medicine. We say that when we establish projects in emergency and disaster, that we say we don't need to have a Porsche to start working. We can start by using bicycles. That's why in simulation, although Dr. Lai presented the new generation for simulation, we teach every year in Hajj the medical students how to do homemade moulaging. So we are using simple stuff to encourage them to carry out whatever is necessary. It's not about advanced stuff. If technology, if advancement is there, that's good. Otherwise, we don't need to wait. So that's just a word for us in Sudan, considering the current situation. And probably final word from Dr. Suleimani before we move to the final session and the closing of the conference.
I would like to thank you all, and I wish prosperity for Sudan, our lovely people in Sudan. We love you all in Sudan. Nice people, humble, eager also to learn. I am proud of having friendship with many people from Sudan, and I think all people. I think there is no reason for anyone not to love Sudanese people.
Thank you very much.
Thank you very much, Dr. Lai, and see you soon. I wish you a quiet shift. Thank you very much.
There are no quiet emergency.
Ladies and gentlemen, I invite you to our last session, supporting evidence-based practice, where our selected abstract will present the last presentation in the other room. So please join us there. Wa assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.